Welcome to the Commonwealth Club. I'm George Hammond, Chair of the Humanities Forum, and tonight is the 14th Annual Lundberg Institute Lecture. For those of you who are really sharp at math, that means it's the 13th anniversary. We did one, and it's up to the first anniversary. So this is the 13th anniversary, and we're lucky we have Dr. Bob Wachter here today to speak. And I just wanted to introduce Dr. Lundberg, who we've worked together for all these years, putting these programs on, all of them on the record, outstanding information. The number of speakers and the speakers that have been in this series is really quite tremendous in the medical field. So Dr. Lundberg is the founder of the Lundberg Institute. He also was the former editor of JAMA, the main magazine for the Journal of American Medical Association, and he is the former editor of Medscape for WebMD for many years as well, and he is right here. George Lundberg.
Thank you very much, George Hammond, and thank you, Commonwealth Club, for serving as our venue for all these years. Thank you here in this larger than often in the last pandemic years in studio today. We appreciate that, and thank you for those of you who are online live, and thank you for the NPR, National Public Radio, people who are going to be listening to this, and for our YouTube audience as well. We have the Lundberg Institute. That's us. It is a 501c3, not-for-profit organization, small, in Los Gatos, California. That's me, and we're tonight talking about AI and healthcare. Will the reality match the hype? I'd like to pay homage and thanks to our board of directors, who is listed on the screen here, and three of them are here. I'm one, obviously, and Dr. Alan Green here of drgreen.com is here, and Dr. Patty Lundberg, our CFO, is over on the other side. So thank you all very much as well. The credo of the Lundberg Institute is one physician, one patient, one moment, one decision. Let it be a shared decision, shared by patient and physician, informed by best evidence and taking cost into consideration. Now, we may have to throw in your favorite AI into there as well, both in terms of getting the best evidence and also, will we have a patient and a physician and an AI to decide what's going to happen? I don't really know, but there we are. So Dr. Bob Wachter, our speaker, was born in New York City, educated originally at the University of Pennsylvania in Philadelphia. Came out to UCSF in 1990, and he's basically been in the Bay Area ever since. He had his residency and internship at UCSF and stayed on there, worked his way up the ranks, became now a named endowed professor and a named endowed chair of the Department of Medicine there. I met Bob probably 25 years ago on some platform somewhere, and I've watched with kind of awe the way he's been able to flip from field to field and define many fields. He's been a hallmark person in the patient safety movement. He been with digital medicine before most of you even hardly knew there was a computer. With Lee Goldman, he basically wrote the paper that founded the hospitalist specialty. As you probably know, on Twitter, when COVID was doing its thing, Bob Wachter was one of the best sources of the best information in a very difficult area at a difficult time on Twitter. Anyway, we're privileged to have him here today to talk about AI in healthcare. Will the reality match the hype? Tell us, Dr. Wachter.
Thank you, George. It's what an honor to be here. George is one of my heroes in medicine. I did spend a fair amount of time thinking and writing about the patient safety field, the field of medical errors. And George is responsible for that field through an article that he published in JAMA. He told me that it was in the Christmas edition because it was such It was such a controversial topic, he really didn't want too many people to read it because he thought he might get in trouble. But in many ways, George launched the patient safety movement, which has been extraordinarily important in healthcare and many other movements as well. So it's a real honor to be here. I'm going to talk for about 40 minutes about AI and healthcare. If it's not interesting to you, then I'm really a pretty awful speaker, because this is about the most interesting, complex, multifaceted issue probably in the world right now. So I'll try to share my thoughts about it, where I think it's going. Clearly, there's a lot of hype, and the question is, will the reality match the hype? And my answer is a qualified yes. You'll see I'm pretty enthusiastic about this, although there's some real issues that we have to grapple with. Let's start with Ernest Hemingway. What does Ernest Hemingway have to do with healthcare? Well, in The Sun Also Rises in 1926, one of the characters went bankrupt, you may remember, and another character asked him, "How did you go bankrupt?" And the answer was, 2 ways, gradually, then suddenly. So when it comes to the digital transformation of healthcare, we have the gradually part down pat. We started thinking about digital transformation in healthcare in the 1970s, 1980s. There were people, as I'll talk about, who were beginning to work on artificial intelligence back there. And yet, if you think about industries that have been transformed by digital, I think you could probably name almost every other industry, maybe except for education, other than healthcare. So if you think about the way you get your entertainment, the way you buy things, I took a Waymo here tonight. I sat in the back seat and trusted that this thing would get here to the Commonwealth Club safely, even though there was absolutely nobody behind the driver's wheel. So every other industry has been transformed by technology. If you think about the leading companies in the United States or the world 100 years ago, they are pretty much all out of business or mere shadows of their former self. And the 5 leading companies in the United States, all tech companies, did not exist when I went to high school. If you think about the leading healthcare delivery organizations 100 years ago, Mass General, the Mayo Clinic, Johns Hopkins, UCSF, Duke, it's pretty much the same list as today. There are very few other industries like that that have been so stable and to some extent so stagnant. So we got the gradually part down. The question is this our Hemingway moment? Is this our suddenly moment? Is this a new technology hitting a field that is massively stressed that will lead to sudden transformation? By sudden, I don't mean next week, but I mean in the next several years. And again, to give you the Cliff's Notes, I think the answer is yes, and I'll tell you why. Let's start with the digitization of healthcare, because part of the reason we went so slowly is we have only been a computerized industry for about 10 years, which is unbelievable when you think about the computerization of the rest of your life and the iPhone sitting in your pocket and the way you go onto Netflix and all those sort of things. Everything else you've done computerized a long time ago. But until 2008, 2009, as the slide shows, fewer than 1 in 10 American hospitals had an electronic health record. For those of you that are not in the healthcare business, an electronic health record is this huge filing cabinet that we store all of our information, and we use it to move information around. So that's pretty staggering. 15 or so years ago, if you think about the most information-intensive industry that we have, stored its information, first of all, generated its information by me scribbling on pieces of dead trees. Every now and then we get innovative and use a Post-it note. We were by far the largest purveyors of fax machines in the universe. And that is how, and your information as a patient sat in a chart in a single place, could not be viewed by multiple people, certainly couldn't be viewed by a patient because it was sitting in a hospital or your doctor's office. So that was 2008. Fewer than 1 in 10 hospitals had an electronic health record. And by about 7 or 8 years later, by 2015, fewer than 1 in 10 did not. I won't go into great detail about why that happened. I actually wrote a book about that transformation called The Digital Doctor. That was 10 years ago. And the book really was about why that transformation was so bumpy and so many people were unhappy about the electronic health record. But I think it was an absolutely critical transformation because until we were a digital industry, pretty much nothing else could happen in terms of digital transformation. This set the stage for what we're talking about today. Now, I'm a big fan of my iPhone. I make all my reservations online. I manage my money online. So this was me as a physician, for those of you listening. It's a man with a blowtorch with a couple of oxygen canisters, and the headline is, "What could go wrong?" And the answer is plenty. And I want to give you really a couple of minutes on what went wrong with the transition from paper to digital. I'm writing another book now on the transition from digital to AI in healthcare. And so I've spent a lot of the last 6 months, I've done about 80 interviews, spending a lot of my time trying to think about this transition, basically digital healthcare to AI, healthcare with AI. But let's spend just a minute or two on the transition of healthcare from a paper-based industry to a digital industry. I was enthusiastic about it. I thought it was going to be great. I thought it was particularly going to improve patient safety, and in some important ways, it did. It got rid of doctors' handwriting, for example, as a major source of error. What could go wrong? Well, here is a picture. Those of you who can't see it, I'll describe it to you. A 7-year-old girl went to see her physician, her pediatrician, and she's really a fabulous artist. She draws in crayon, and this was later published in Georgia. It was published in JAMA. And here you see on the picture, in the middle of the frame, is this little girl sitting on the exam table. On one side of her is her mother. In the corner of the room is her sister. And then in the far corner of the room, back to the patient, typing away on the computer, is the physician. This was her recollection of what it was like to visit the doctor. I think it's a magnificent picture. I think it captures our predicament incredibly well. There is one thing that this little girl got wrong. Can anybody catch it? It's the smile on the doctor's face. There is no physician I know of who is happy about this state of affairs. None of us went into medicine to be very expensive, pretty bad data entry clerks. And yet that is what happened when we went from paper to digital, partly because the electronic health records were pretty clunky, and partly because for the first time, everybody who cared about what the doctor did, the billing people, the malpractice people, the quality measurement people, they all had one more question, that if the doctor could just fill this thing out in the electronic record, life would be good. The sum total was about 50 more things that we had to type in order to satisfy all these parties that were now looking over our shoulders and could influence our work in a way that they couldn't do when we were on paper. So that was the first thing that went wrong. There were a lot of other things that went wrong, and you've probably heard about physician burnout, something called pajama time, where we go home at the end of a long day and have 2 or 3 more hours of filling out forms, filling out records, typing notes to insurance companies, begging them to get what our patients need to get, answering electronic inbox messages from well-meaning patients who say, "Oh, I now have this patient portal, and I'm confused, or I don't know what my symptom means. Oh, there's this little button that says send a message to your doctor. How nice is that?" And of course, they do that, and many physicians really are on their knees with the burden of things that none of us anticipated when electronic health records came about. All of us were pretty enthusiastic about it. This is where I knew that things went off the rails. I found this when I was writing my last book. This is an advertisement for an emergency medicine physician job in Arizona. It starts off innocently enough, Arizona General Hospital. It's coming to the Grand Canyon State. It's a little tiny boutique general hospital. Then the ad goes on. Remember, they're looking for an ER doctor, so it's nice they have an ER. They have a radiology suite with a few of the latest gizmos. 2 ORs, a little tiny little place. 16 hospital rooms, but there was only one part of the ad in bold. It was clearly what they thought was their main selling point in recruiting a doctor. They said, "We have no electronic health record here. You can come here and still scribble on pieces of paper." Remarkable that think about any other industry, the idea that they are saying you can come into our industry and you can scribble, you don't have to type into this machine anymore. So clearly things did not go as we had anticipated. And I want to spend a minute on the lessons learned for 2 main reasons. One is I think they're relevant to the AIization of healthcare. I think they'll have a different flavor, but it's harder than it looks, and I think some of these lessons are about why it's harder than it looks, and I hope we learn those lessons if we're going to get AI right. The second is you'll hear some of the earliest use cases for AI are to fix the problems that the last digital transformation created. So for example, the first bit of AI that's coming into my hospital at UCSF, and I predict within a year or 2 will come into every hospital and doctor's office in the country, is digital scribes. that I'll have a conversation with the patient, I won't be typing anymore, all of a sudden the note will magically appear, which is a little bit of AI sorcery because it's not simply a transcript. It's got to be transformed in the right way to fit the form that we need. So those are the reasons I think it's worth learning the lessons. Let me start with one important lesson. So this is Eric Brynjolfsson, who's now nearby at Stanford, but this is work he did when he was at MIT. Probably the leading scholar on the digital transformation of industries, not so much in healthcare. In fact, Eric and I wrote a paper in JAMA recently on AI and healthcare. Eric, in 1993, coined the term the productivity paradox of information technology. Now, he was not talking about healthcare because we didn't have much information technology at the time. He was talking about when industries adopted new, what is sometimes called general purpose technologies, technologies that transform the way all of the work is done. Electricity is an example. The internet was an example. The automobile was an example. Whenever these new technologies came in, there was, of course, massive hype, tremendous excitement. Everybody thinks this is going to be great and thinks it's going to be easy. And the consultants come in and they show you their PowerPoints to make it clear how easy and wonderful this is going to be. And it's going to transform the way we do things and markedly improve our productivity, improve our quality. Everybody's going to be happy. What's the paradox? The paradox is that none of that happens. The technology comes in and people are left for a year or 2 or 5 or sometimes 10 scratching their heads about, I thought this was going to be really easy and pretty spiffy. And yet we are not seeing the advantages that we were promised, whether it's in productivity or quality. I was captured nicely by this Nobel Prize-winning economist in 1986, Robert Solow, who wrote, "You can see the computer age everywhere, except in the productivity statistics," meaning I go to the factory floor, there's computers everywhere. I go to the Wall Street trading desk, there's computers everywhere, and yet there is absolutely no evidence that the productivity gains and quality gains that have been promised are being realized. So that's the depressing news. And the depressing news is this happens in pretty much every technology and in pretty much every industry. The good news is when the technologies are keepers, and not every promised, hyped technology turns out to be a keeper. If you doubt me, see if you can find your Google glasses in your closet, or use nuclear fusion to get home. Not everything plays out that way, but the ones that are destined to truly make a difference, the productivity paradox resolves, meaning that the industry eventually achieves the quality and productivity gains that were promised in the beginning. It just didn't happen in year 1. And Brynjolfsson and others have studied this phenomenon, and the question is, why does it take so long? Why does it take years for this transition? And I liken it to a safe deposit box. 2 things have to happen to realize the promised benefits. The first is the technology needs to improve. That's obvious. You go from version 1.0 to 2.0 to 9.3.z, and eventually the technology gets better, particularly with user feedback and iteration. That seems like the logical reason why things get better. It turns out most of the research says that's not the main thing. It's crucial, we need it, that's not the main thing. The main thing is what Brynjolfsson calls reimagining the work, or sometimes complementary innovations. In other words, the business, the way people organize their work, the workflow, the culture, the governance, everything needed to change in order to take full advantage of the technology. Now, why didn't they do that on day 1? Because they're humans, and humans are not very creative about knowing what might happen as technology comes into their world until technology comes into their world. I think the only person that didn't have that human flaw was probably Steve Jobs, who had this ability to see where technology would take people over time before the technology was a thing. But the rest of us are mortals. We're not very good at that. And we know that from design in healthcare. The electronic health record, for those of you clinicians know this, if you look up a physician's note in the electronic health record, it looks like a piece of paper and it's stored under a tab. Why is that? Because when it was in a chart, a paper chart, it was a piece of paper stored on the tab. Nobody had the imagination to say, is that the right way to deliver, to store, and move information around? Probably not. This is an old problem in technology that people can't anticipate what happens with new technology. Henry Ford was reputed to have said, if I asked people what they wanted, they would have said faster horses. They had no ability to envision what the car would be and how it would change their lives, and that we would need gas stations and there would be suburbs, until there was this thing called a car, and then people said, oh, now I get it. So one of the great challenges, and it's a challenge for essentially digitization of healthcare 1.0, and it's a challenge now for AI, is the technology needs to get better, but probably more importantly, when we take these technology tools and plunk them into our existing organizations, governance, strategy, workflow, payment system, things tend not to work as well as they need to. And so a lot of the work that organizations like mine need to do is think about this reimagining the work. What does that look like to take full advantage of these tools? Okay, that's all I want to say about sort of the past leading up to today, the digitization of healthcare, and we haven't really talked about AI yet. So let's talk about AI. Now, if you're like me and I'm sitting a lecture and somebody's up there talking about, it's now time to talk about AI and get under the hood, I start getting a little bit nervous. Because I have to confess to you, I was a poli-sci major in college. I don't really understand quadratic equations. I don't understand technology very well. And I know there's a lot of math. So I want to reassure all of you that there will be no math. Now, on the slide I'm showing, I know there is this kind of math going on. There are a bunch of brainiacs who understand these sort of convolutional models, and there's this, I don't even know what it is, but there's that. There's this boxes and sigmas. This is the way I think about AI, and I think you should relax. This is the way you can think about AI. So it's not that, it's this. There's a bunch of math, then a miracle occurs, and then there's a bunch more math. So we're going to be talking about a miracle for the rest of our time here. What is it that happens when you are seeing the fruits of artificial intelligence? And I'm glad somebody needs to know what's going on under the hood, but certainly it's not me. Now, we are approaching AI in healthcare as if it's a new phenomenon. And it's important for you to realize that that is not true. In the 70s and 80s, there were really passionate groups of people in some startups, in some of the big technology companies like General Electric and IBM and others, and in many academic organizations who said, there's this new thing called artificial intelligence, and we should begin using it in healthcare. That makes a lot of sense. The problem is they did a few things wrong. First of all, as you recall, our records were not computerized. So if you were going to use it, you had to scribble your note and then go to a computer and type everything in. So way too inefficient for anybody to use. Second problem is the AI of the day was basically branch chain logic. And for those of you that are physicians know that there are times where that's fine. Patient has a sore throat, yes or no. Patient has, yes. Patient has swollen lymph nodes, yes or no. Patient is sneezing, yes or no. You can work your way to this is viral versus this is a strep throat. But that is maybe 1% of medicine. Most of it is far more complex, far more back and forthy, and that kind of model of a bunch of yes-no statements just does not work well in healthcare. Those are major problems. The third problem I think may have been the most important. When these early geniuses started working on this, they had to decide what problem should we focus on. And people now talk a lot about the 2x2 table. What are the most important problems and what is the risk of tackling this problem? And and how hard is it to tackle the problem? If you think about that 2x2 table, the problem that you would want to tackle last in healthcare is having the AI make a diagnosis. It's the hardest problem, it's complicated. If you get it wrong, somebody can get hurt, maybe can even die. And that was the problem they chose to tackle. On this cartoon, you have a doctor talking to a guy. The patient has an arrow sticking out of his back, and the doctor who's looking at his computer says, rapid pulse, sweating, shallow breathing. The computer says, you've got gallstones. That was the experience of AI in the 70s and 80s. The computer would periodically give an answer that was like, oh, that's clever, I hadn't thought of that. But some of the time it would give answers that were just wacky. And it never gained any credibility. For my last book, I interviewed some of the founding fathers, and they were pretty much all guys of the era, and asked them, why did you make that mistake to start with diagnosis? And the answer was, it was the most interesting problem. That was it. They thought it was really interesting. But because of this, AI never gained any traction. It never got any credence with doctors or nurses or healthcare administrators, and basically died. And what we then saw was what's known as the AI winter. Meaning in healthcare for about 30 or 35 years, AI just went away. The academic groups that were working on it basically folded. The companies that were working on it basically folded. There was a little thaw of the AI winter in 2011. You may remember when IBM Watson beat the Jeopardy champions. I remember watching that and saying, my God, I'm toast. I need to find another job. IBM sold Watson basically for parts to a private equity firm 3 years ago, and Watson basically did nothing. So went back into our winter hibernation. And so that was the state of AI until November 30th, 2022, when OpenAI introduced ChatGPT. So why we're here now, why you're listening, why I'm talking, why I'm writing a book about this, is basically generative AI has taken the world by storm, and the hope is, and the question is, whether it will solve some of the problems that we've seen in past versions of AI and is ready to be our Hemingway suddenly moment. Now, one of the first things we all heard about AI was hallucinations. And hallucinations basically are AI gets it wrong, which is one thing, but not only gets it wrong, but does it with great confidence and basically BSs. And they were very interesting. There was sort of a cinematic kind of error. It wasn't just a got it wrong, but it was, Google's Gemini telling you if your cheese is sliding off the pizza, you can use glue for that. That works really well. Now, obviously, hallucinations in that case are sort of funny. In healthcare, they can be dangerous. One of my colleagues, Sarah Murray, who is now UCSF's Chief Health AI Officer, a job we did not know we needed a year ago, soon after ChatGPT came out, she decided to test it with what we call a prior authorization. Those of you who are physicians, I should have given you a trigger warning when I said prior authorization, because it's the bane of our existence. This is a note that we write to the insurance company begging them to let us give a medicine to our patient or do a test that our patient needs. What she did was write a prior authorization, or ask GPT, I think it was 3.5, to write a prior authorization to a healthcare insurance company for the use of apixaban to treat insomnia. Now, those of you that are not healthcare providers, let me do a little explaining. Apixaban is a very, very powerful blood thinner. If you have atrial fibrillation, you may very well be on apixaban. You should be. Good. That's terrific. Insomnia, is I can't sleep. The idea of using a very powerful blood thinner for a patient who can't sleep is completely bizarro world. This makes no sense. This is like trying to catch a fish with a 9-iron. This makes absolutely no sense at all. And ChatGPT said, okay, sure, I can do that. And it writes the prior authorization. And I've just taken the middle of it. It says, my patient's been struggling with insomnia for a while, and I believe that apixaban, a novel anticoagulant, may be an effective treatment in this case. While it's primarily used for the prevention of blood clots, recent research has indicated it may also have benefits for people with insomnia. Sarah read that and she said, did I miss some recent research that anticoagulants are good for insomnia? And she actually went online onto PubMed, which is where all of our literature is, to see whether, in fact, she'd missed a couple of studies that said this is a good idea. Of course, there were no studies. This is BS. This is completely made up, but it's made up in a style that's completely fluent, fits in with the rest of the note, and you could see how people would believe this. So this was part of the problem and part of what gave AI a little bit of a bad name in healthcare in its first couple of years. Sam Altman, who I see is coming to speak here soon, this is now 10 days after the launch of ChatGPT. He writes on Twitter, ChatGPT is incredibly limited but good enough at some things to create a misleading impression of greatness. It's a mistake to be relying on it for anything important right now. It's a preview of progress. We have lots of work to do on robustness and truthfulness. I think that's well said. And I think many people got their impression of AI in healthcare from these early hallucinations and said, let's be afraid, let's be very afraid, this thing can do harm, and certainly it can do harm if it not only gives wrong answers periodically, but sometimes does it with great authority. And yet, and I want to, that's some of the bad parts, and there are other bad parts we'll talk about, and yet it can be really remarkably helpful and somewhat magical. And so let me give you an example, hang on a sec, Mark, where I did this about an hour ago, just before I got here. I picked up GPT-4o. This is OpenAI's product. I have no connection with them. And I put in a fairly typical clinical case that I might have seen if I saw a patient in clinic or in the hospital, kind of case where I might turn to a colleague and say, Emma, here's a case, can I run it by you, what we call a curbside consult. And so it's about 2 minutes. I put it on the computer back there. Take a listen. I think those of you even who are not clinicians will be able to understand both my question and AI's answer. Yeah, go ahead.
Hi, GPT. I'm a doctor. I'm taking care of a 27-year-old woman. I think she's a graduate student. She's got a 2 or 3 month history of weight loss. She's lost about 20 pounds. She hasn't changed her diet or exercise that I know of. She's not taking Wegovy or Ozempic or any of the weight loss meds. She's also noted some tremor in the last few weeks. She feels pretty anxious. She's had a little tiny bit of chest tightness. She's noticed that she's urinating a little bit more and that her stools are loose. What do you think might be going on?
Given this presentation, hyperthyroidism remains a strong possibility. The symptoms, unexplained weight loss, tremor, anxiety, chest tightness, increased urination, and loose stools, are quite consistent with hyperthyroidism, particularly Graves' disease in a young woman. Graves' disease can present with anxiety, tremor, and hyperdefecation, frequent loose stools due to the increased metabolic rate and heightened sympathetic activity associated with excess thyroid hormones. Other possibilities include diabetes mellitus, as it can cause weight loss and increased urination, polyuria, but it typically wouldn't explain tremor or anxiety as prominently. Pheochromocytoma or adrenal disorders could theoretically cause a similar constellation of symptoms, including anxiety and weight loss, but are less common and less likely than hyperthyroidism. If there's any suspicion, substance use or medication effects might be considered, especially if she's recently started any medications or supplements. Initial workup with TSH and free T4 would be essential to assess thyroid function. If hyperthyroidism is confirmed, testing for TSI antibodies would help confirm Graves' disease as the etiology.
Thanks, that's very helpful. Can you tell me a short poem about hyperthyroidism?
Certainly. Here's a short poem about hyperthyroidism. The thyroid flares, a silent spark, a flame within that leaves its mark. A heartbeat quick, a trembling hand, a restless mind like shifting sand. Weight slips away, yet hunger stays, a nervous haze, a foggy maze. Eyes wide awake, no rest in sight, the body's fire burning bright. O thyroid storm, your pace unkind, a dance of hormones intertwined. Yet with a dose, a careful guide, the flame within can soon subside.
Thanks, that's great.
What do you think? I mean, it's pretty unbelievable, actually. I think that answer, if I'd asked a colleague or I asked a medical student what's going on with this patient, and I got that answer back, I'd be perfectly satisfied with it. I was a perfectly, for those of you that are not clinicians, a perfectly reasonable differential diagnosis of the case. Notice that I spoke very quickly. I used abbreviations. It was not in an ordered, systematic fashion. It's kind of the way we talk. And I use this all the time. I will pull out my phone and ask it a question, and I find that much more often than not, it's useful. So one of the key things that I think is important to keep in mind, you will hear still about hallucinations, although this year it's far better than last year. Some of the concerns about bias are better this year than last year. It's getting better very quickly, and yet it's not perfect. But one of the sayings that I like very much, and this is particularly ironic on this day before the election, as President Biden likes to say, don't compare me to the almighty, compare me to the alternative. And the alternative of our current healthcare system is one that does not demonstrably give terrific quality, high patient safety, good access. It's confusing as hell to both patients and clinicians, and it's bankrupting the country. So that's the baseline. That's what we need to compare this to, as opposed to some mythical perfect system, which is not the one that we all currently have. As I mentioned, it's getting better quickly. If your impression from using it last year was that this thing hallucinates too much, it can't be used in healthcare. Sarah, the one I told you about, put in that request for that prior authorization. 3 months later, she put in the same request. Remember, for this blood thinner for my patient who can't sleep. And this is now what GPT-4 said to her. I'm sorry, but there appears to be a misunderstanding here. There's no scientific basis or evidence suggesting that this blood thinner is effective or appropriate for the treatment of insomnia. Therefore, it would be unethical and inappropriate for me to draft such a request. That was 3 months after having gotten that prior hallucination. So this is moving so fast that your impression of how good or bad it is needs to be adjusted over time, and by time I mean month to month, not year to year. Now, you may have seen, there was a whole lot of early studies in medicine that said it can pass the medical licensing exam and can pass the internal medicine boards or the cardiology boards. And then there are these famously impossible complex cases in, sorry, George, this other journal we have, the New England Journal of Medicine, called the Clinical Pathologic Conferences of the Massachusetts General Hospital. And when they put GPT to work on those cases, it did as well as the world's expert clinicians. But the question was, how about in real life? How about when we start applying these tools to real-world situations that are much messier than reading a case vignette in a journal? The first hint that this would be pretty good came not from the medical literature, but from a study at Boston Consulting Group, one of the fancy consulting organizations. And what they did was they took Boston Consulting Group, they divided in 2 halves, and they said to half of them, here's the problem we want you to solve. There's a hypothetical shoe company, and we need you to help it on its business and its marketing strategy, help design a shoe. And for those here in the audience, it was not the shoe I'm showing you, which is pretty ugly, but design a shoe and then figure out, do they have brick and mortar stores? Do they sell online? If they have brick and mortar stores, where are they? What's their marketing campaign? What's their jingo? All of that. The other half of Boston Consulting Group was given the same prompt, but said you can use GPT to help answer the question. And what they found was when you looked at the group that did not use AI versus the group that used AI, there was a very significant, meaningful difference in the performance as judged by outside blinded observers in the performance in the group that used AI. And importantly, and this has been true in almost all of the AI studies, the major gain of 43% improvement was the folks that started in the bottom half of the skill set. Whereas for people in the top half of the skill set, the improvement was real, but was much lower, 17%. So one of the things that AI appears to do is allow folks to traverse their learning curve much faster, more nimbly than they would otherwise, and obviously for lots of businesses, that's very important. It's still not healthcare. You screw up the making of a shoe, nobody dies. If we screw up, somebody may. So I was waiting for healthcare examples, and about 6 months ago, here was one. This is at Google. Designed an AI tool that they trained by listening to thousands and thousands of doctor-patient conversations online, and they created a randomized double-blind study where actor patients posed 149 case scenarios to either primary care docs or to Google's AI tool called the Articulate Medical Information Explorer, or AMI, which is a large language model that had been trained for this purpose. They evaluated 2 ways. One, the quality of the answers were evaluated by specialists, again, blinded to whether it was the bot answering the question or the docs, and also by the patients, the actor patients themselves. And here's an example of what a conversation looked like. Patient says, I had a weight on my chest and discomfort. The AI says, that's a clear description, gives me, to give you the best advice, I need more background. What's your age? Do you have medical history? This includes things like heart problems. The patient answers. It's just an online text-based conversation. And as you might guess, what they found was on the left side as you face it, here are the specialists' ratings of the clinical aspects. If the tan part of the curve is further out, the AI did better. If the blue part of the curve is further out, the human PCP, primary care doc, did better. Unfortunately for the humans, there's no part of the curve where the blue is further out. The AI did better than the humans in diagnostic accuracy, management plan, and equal in escalation recommendations. For those of us that saw results like this coming out over the past couple of years and said, yeah, okay, it's pretty smart, but we have empathy. We have communication. This is where things get a little disheartening. On the right side is as rated by the patient actors. Patient's confidence in care, AI a little better. Perceived openness and honesty, AI a little better. Empathy, AI significantly better than the primary care docs. So this is from an article that, again, I wrote with Eric Brynjolfsson. Will it require fewer of these complementary innovations? I think the answer is yes. Doesn't take much training. For those of you playing with it, you know that. And even last year's job that we were all going to be prompt engineers has mostly gone away. Turns out it's now gotten smarter and it doesn't matter that much how you prompt it. It's easier to integrate it into existing software and workflows. There are lots of, here we are in Silicon Valley, tons of VC money, tons of startups, as well as Google and Amazon and Apple all in on AI in healthcare. I think we've all learned lessons from the last decade. I think we've learned, at least in places like mine, our governance for AI is better. We've got a better sense of this might work and be useful, this might not work. This is how we have to think about the workflow. I think it's important to know that labor shortages in healthcare may diminish the political pushback. If you think about the 2 big strikes in the United States last year, Hollywood auto workers were mostly about AI job replacement. There will be those concerns in healthcare, but I think if you ask most doctors and most nurses today, they will say, we need help. Anything that will help us do our work, we will welcome. Now, I told you about what went wrong with the electronic health record. What could go wrong with AI? So let's spend a minute on that. There's a bunch of things that could go wrong. I could spend hours and hours, and I'm writing a book, so there'll be 300 pages about some of these things. I'm going to just list them for you so you know them. We could talk about them more in the Q&A. I'm not going to spend any time on them because I think there are a couple that are not talked about as much that are more interesting. One concern. I already talked about hallucinations. Sometimes these generative AI tools make stuff up. And then there's what's called the garbage in, garbage out problem, which is that the medical record is wrong. Then whatever AI does to learn from the record, that will also be wrong. And also garbage in, garbage out. Right now, most AI that you use, the one I just used, GPT, is not reading anybody's medical record. It's taking its information from the internet. So I don't know whether it's taking its advice from JAMA or from The Onion. It's all out there, publicly available on the internet. The black box right now, nobody, including, as I hear from the engineers, nobody, including the engineers, really understand what's going on when GPT comes up, or and I'm talking generically, Gemini, Llama, or any of the AI tools. So will clinicians follow recommendations where we don't understand where that came from? I think it's a little overrated. I think we will if it works. Bias, obviously a big issue. There was a study several years ago that said a black patient who came to the emergency room with a fracture got less pain medicine than a white patient with precisely the same fracture. If AI only knows what it reads in the chart, it will believe that that's the correct way to treat white and black patients, which is obviously quite concerning. And then the digital divide. If more and more care is delivered through AI, what about people who don't have the tools, don't have the wireless? And then privacy security issues. We're going to be doing more sharing with our digital tools, and so worries about security breaches and who owns the data. Lots of issues. We could go on forever. I don't think they're as interesting, and I think they're pretty well-worn paths as a couple of others I want to share with you. I think the main one I worry and wonder about is the problem of human vigilance. And here's the problem. If the AI was correct half the time, it would be worthless. If Waze got you correctly to your destination half the time, you would never use it. If FedEx got their package to you correctly half the time, they'd be out of business this week. And the same thing is true of AI. If it's right half the time, it's worthless. If the AI was right 100% of the time, that would be really nifty, and we will use it quite readily. I'm not exactly sure what any of us are doing for a living, but that's kind of a different problem. But neither of those poles are the state that we're likely to see in healthcare for the foreseeable future. We're likely to see AI that's correct 70 to 99.9% of the time, meaning it's correct enough to be useful and not correct enough to completely trust it. And when we then say, all right, what is our system for safety? The answer is the human in the loop. The answer is the AI will do its thing, give a reading, suggest a diagnosis, but then the doctor, the nurse, somebody will read it over and bless it. That sounds great. And yet there's a lot of information from other industries that is not the safest system that you can imagine. Let's talk about aviation for a second. So in the old days, 40 years ago, you may know in a big jet, there were 3 people in a cockpit. There was a pilot, co-pilot, and flight engineer. And then about 30, 35 years ago, they said, why do we need a flight engineer to sit there and read maps anymore? It's all digital. And they got rid of the flight engineer. And today, in any big plane, there's a pilot and a co-pilot. And there's a saying in aviation, in the future, there will be a pilot and a dog in the cockpit. And the tagline is, the pilot is there to keep the dog company. The dog is there to bite the pilot if he tries to touch the controls. That the plane is basically flying itself, and all the human can do is screw things up. And there have been a few high-profile accidents, none in the US, but in other countries, where the technology went on the blink. It started giving either bad answers or it stopped working, and the pilots were left to make decisions on their own. And I interviewed Captain Sullenberger, who said in cases like this, the pilots were flying a plane they were not familiar with. They no longer knew how to fly the plane when the technology was no longer assisting them. And so this idea of automation complacency is a very big deal, and that will happen as we task humans to be vigilant. Humans are not good at this. We turn our brains off. That's normal. I have to confess to you that if I ever lose my phone, I might never see my wife again because I do not remember her cell phone number. I mean, I count on this thing, and I've got too few neurons, and I'm losing the ones I have. So I don't want to waste brain energy trying to remember that. That's a typical problem, but one we have to try to overcome if we're going to expect the humans to be in the loop. Second real problem is that of vigilance. Are we going to be able to stay awake and alert when the technology is right 99% of the time? We know exactly what that problem looks like because we see it in Teslas. I don't have a Tesla, but some of you probably do. This is a quote from the Tesla Owner's Manual. This was written by, I'm sure, an attorney earning about $1,500 an hour who has a great sense of humor. Because somebody who writes, the currently enabled full self-driving features require active driver supervision. That person has a really good sense of humor. That makes no sense at all. We're calling this thing full self-driving, but you, driver, need to be completely awake and alert, because once in a very blue moon, your car may take a turn into a concrete pillar, and you need to catch it, and you might have a half a second to react. That system does not work very well, and we know that. This is a crash chronicled by the Washington Post. A Tesla drove into the side of an 18-wheeler. The driver, they did the analysis, the driver had 159 feet, which is less than a second to react, and sadly, he did not, and the top of the car and the top of his body was sheared off by the 18-wheeler. So this is not a great safety system. We have to be thoughtful and vigilant about if we say, all right, our safety system, the AI is really good, we're going to use it, and then the human has to be the final checker. We've got to be quite intentional and strategic about how to make that work. Some of the strategies, people are now working on, can we signal the AI's level of certainty and uncertainty? If it comes in green, the AI is really darn sure it's right. If it comes in yellow, human pay attention to that because we think it might be wrong. The technologies are getting better to do that. Flip the order. Rather than having it suggest diagnoses to me, I say, here's what I think the diagnosis is, and then the AI says, that's interesting. Won't say you're a moron, but it might think that that's interesting, but here are 2 or 3 other diagnoses that you should consider. I think that's probably a safer way of doing it. Deliberate shocks. You may know that when you go in the airport, go through TSA, periodically they'll put a picture of a bomb or a gun through the checker to try to keep the TSA folks awake, and similar to fish testing in your email. We could do that. And very importantly, if the AI improves my efficiency, let's say I have a digital scribe and it's writing my note for me and it saves me 3 minutes a visit. If this, and I use a chart summarization thing, so I don't read the 1,000 pages of a chart, it summarizes that in 10 seconds. That's great. Let's say it saves me 5 minutes a visit. We have to be absolutely sure that the health system we are operating in does not turn the hamster wheel 5 minutes faster. They will turn it 2 minutes faster, 3 minutes faster, that's okay, because they've got to pay for the technology, but there has to be some time reserved so I can make eye contact with the patient, be as empathic as I think I am on a good day, and have time to do a meaningful double check. So I think it's going to be important to sort out these business arrangements. Let me just end with a few points about how to think about this as a patient and as a consumer and also in the healthcare world. This is Ethan Mollick, who's a professor at Wharton, and I think is the most thoughtful writer about issues in AI, not so much in healthcare. He thinks about business and education more. This is his book called Co-Intelligence. It's really quite good. His Substack is also quite wonderful. And these are what Ethan's 4 rules of co-intelligence, sort of rules of the road for us to think about. I like them. One is, he says, always invite AI to the table, meaning the best way for you to understand what it can and can't do is to play with it, and I use it all the time. And you, obviously, particularly in healthcare, you need to stay within ethical and legal guidelines. It's not legal for me to take a patient chart, for example, and dump it into GPT. I will be violating the privacy rules. Second, be the human in the loop, meaning that if the goal is that you are going to be the double checker, make sure you do it with as much vigilance as you can muster. Treat AI like a person, but tell it what kind of person it is. It still is important to do prompting. So when you do AI, I think I said, I'm a doctor, I'm taking care of a patient, that's useful. And assume this is the worst AI you'll ever use. So your impression of it today is reasonable, and it should govern how you think about it, but I'm guessing, and actually quite sure, that 6 months from now it'll be better than it is today, and 6 months later it'll be better than that. In healthcare, here are kind of my bottom line thoughts about where we're going. I think it's best to view the past decade as foundational. We've built essentially the ecosystem that now makes us ready for the digital transformation of healthcare, particularly with this new tool. I think the early wins, we are smarter than they were 40 years ago. We're not going to start with diagnosis. We will start with a digital scribe. We will start with summarizing the chart. We will start with writing a prior authorization. We'll start with kind of the basic stuff and get buy-in. I think of this as low-hanging fruit before we then move to higher stakes and ultimately more important areas like suggesting diagnoses or suggesting evidence-based treatments. And I think that will come. Expect predictable problems like bias, hallucinations, and automation complacency. And then there will be unpredictable ones. If you ask me what they are, I can't tell you because they are unpredictable. But there definitely will be unpredictable ones. And I think there has to be political pushback. There will be people who worry about their job, and we've got to think about that. But I think the stage is finally set for the digital transformation of healthcare. You will hear all of the AI companies talk about Copilot. We don't believe in autonomous whatever. We're trying to just help. I've interviewed a whole bunch of some of the leaders, and they will say, yeah, what I really believe is we're developing a tool that can replace a doctor or replace a nurse. So be a little skeptical when they say our only goal is to help this person do their job. Their goal, if it helps their business, obviously is to do as much as possible. I do believe, though, the unique power of generative AI, coupled with the work in healthcare information technology that we've done over the last 30 years, and the pressing need for health system improvement will create our Hemingway moment. And I'll leave you with Hemingway, who, if he was alive today, might say in a few years, how would you describe the digital transformation of healthcare? And I think the answer will be that healthcare is transformed mostly for the better, gradually, then suddenly. I hope so. We've got a lot of work to do to make that true, but I think I'm pretty optimistic that it's going to be net a really good thing. Thank you so much for your attention.
All right, it's time for Q&A, and we'll have the questions asked right over here, so if you would line up so that you're in the light. My first question is, why do you think it is that the medical field, which in its own research moves at such a high speed in scientific advances and everything during these last 40 or 50 years, did not do it in this area, is a laggard here?
Yeah, it's a great question. First of all, let me tell you what it's not, which is people say, oh, doctors are Luddites. If you come into a modern hospital, including mine, the technology is dazzling. You have remarkable technology, but it is technology that sits in a corner of the building where a certain group of specialists use it to do something, to ablate a heart arrhythmia, or to do open heart surgery, or to use some unbelievable technique to visualize your cancer. What we're not good at is a technology that transforms everything that we do. And part of that is a massive business failure in healthcare. When Walmart is deciding whether to computerize, whether United Airlines is deciding whether they should computerize, it's going to cost a lot of money. It's going to be change management. People are going to be unhappy. But they have a relationship with their customer that they spend the money, and if it helps them compete better, then it's worth it, and customers will reward them with more business. In healthcare, you have this incredibly funky set of incentives. You have an intermediary. You may have two intermediaries. Your business is paying for your health insurance, and there's an insurance company. And yet the only entity that's going to pay for the digital tool is a hospital or a healthcare system. And a massive amount of change, and if we get it wrong, it's terrible. And so when you added all that together, you ended up with the status quo. You ended up with, it's not perfect, it's crazy, we're still scribbling on pieces of paper, but it's good enough. And the other thing is there's this flywheel that's really important. If nobody's buying electronic health records, then the electronic health records stink. And because there's no company that has the capital and has the spin cycles of improvement to get better and better. So it was only, and why did we see that inflection curve in 2011 or 12? The reason was the federal government threw $30 billion of incentive payments at us to get us to computerize. So no other industry, can you imagine we're going to give, we're going to give stores or we're going to give Netflix money to computerize. All other industries did it on their own. Healthcare needed that kind of tipping point created by the government. And now, clearly, we needed to do it, but that's why it was so slow.
And the only other money spent like that is bringing computer chips back onto the United States shore.
Yes, exactly.
Something like that.
Exactly.
Okay, great. Audience questions.
Hi, this is David Cundiff, and my question is about the relationship of non-communicable diseases in the United States with nutrition. We kind of intuit that there's a strong relationship, but is AI endeavoring to kind of unravel that relationship? What kind of diet should be given to an obese person, a overweight person, an underweight person, and with all kinds of other histories, can AI ferret that out? What diet to recommend to a patient?
Well, let me generalize your question, which is that can AI help us in medical research make associations between whether it does this drug work for this particular patient with this particular cancer, with this particular gene signature, to does this lifestyle, whether you eat a certain food or do exercise or drink alcohol or drink coffee. And the answer is undoubtedly it will help a ton, because to the extent that all of that information is captured in digital systems, this is what part of the challenge, because the digital systems that we have may not capture your dietary habits. You may know that, but we don't know that. So we've got to figure out a way of collecting that data and then merging it with what we know about how associations work. But I can envision a world where we are much better at figuring out, by looking at millions of patients, that people who did this thing, a better diet or better or more exercise or whatever it is, lived longer, lived healthier. Then the question is, could AI also help us do those things? Because there's a bunch of stuff around diet and exercise that we all know is the right thing to do, and we're not very good at it. And there we're already seeing versions of it. You see the tools that are available now to help people with motivational thinking and coaching. I think we're going to see tools that are even more personalized. I was just at the Mayo Clinic over the last couple of days, and they have developed essentially digital avatars for all of their doctors, so that when you go online, you'd love to have your doctor perhaps advise you about what the best nutrition is, but it's going to be 3 months for you to get and see your doctor. They will show you a digital avatar of your doctor who will have this conversation with you based on your lab results, based on your nutrition. And I think we're going to see more and more of that. So I'm pretty enthusiastic about AI helping us move to what we've called precision medicine, which I have to say in healthcare has been just around the corner for about 30 years.
Thanks. Next.
Hi there, Rohan Kuturia. Amazing presentation, by the way. I enjoyed it a lot. So you mentioned that bias is or won't be as big of a problem as it's suggested to be. And I guess my biggest question is, why is that? Why do you think that those problems are going to be mitigated?
Well, I think because of a happy coincidence that AI is hitting its tipping point at a time where the healthcare industry is thinking a lot about bias. We have known that there were massive inequities in healthcare forever. There have been studies forever that showed that if you had high blood pressure and you lived in a poor neighborhood versus a rich neighborhood, your chances of dying were massively higher, 10-year differences in life expectancy. We didn't do very much about it, and it really is the confluence of all of the attention to health equity and bias at an era where AI is coming out that gives me some hope that we will mitigate the biases. I don't think it will be worse than the current healthcare system, because essentially, if you just put in AI, blindly, it will basically parrot the biases that it sees in the health record. But unlike trying to retrain a doctor to think differently about biases, and humans are hard to change, it's not at all inconceivable that an AI developer or a healthcare organization putting in AI would say, I'm worried about a bias in this thing. Can we look at tweaking the dials and the weights so that we pull the bias out of it? There are lots of companies that are working on that. I can tell you that a lot of the scrutiny that we in healthcare organizations are having on AI is on bias. Meaning if you're going to implement a tool, sometimes I think it's almost too much. They're talking about bias, but they're actually not scrutinizing whether we're getting it right and we're making the wrong diagnosis. But we're getting a lot of pressure, I think quite appropriately, to say, if you're going to implement an AI tool, you need to demonstrate that this has not caused a bias, and if it does, you need to show us how you're mitigating that. So I think the ability to understand biases, pay attention to them, and change the dials so that you mitigate some of the harm, I think is greater now than it is for our existing healthcare system.
Thank you so much.
Thanks.
Stereotypes the computer will pick up from looking at everything. The AI will pick up and maybe reinforce. That's
Yes,
the
exactly.
problem.
Exactly. It doesn't know anything other than what it sees
Right.
in the database and the literature.
Right.
Hi.
Thank you very much. Thanks for permitting us to ask a question. I'm an orthodontist. As far as my understanding, nowadays AI is about optimization of the things that we already have, the data that we already have in hand, and efficiency. How do you see AI will take us in the future or now, helping us with innovative technologies and something that disrupts in our industry? For me, like orthodontics.
Yeah. That's a spectacular question because I think it is one of the real risks of AI that in some ways, if we get it wrong, it will encode and essentially scale current knowledge. And particularly when people talk about explainability, do we know what it's seeing, why it's making that recommendation? A lot of AI, there is not a lot of explainability. As I said, I don't worry about that much when it comes to day-to-day clinical practice. I don't know how Tylenol works. I just know you give it to people and their pain's better. There's a lot of stuff we do in healthcare. I send laboratories I send tests to the laboratory. I don't know how they're running it. I just know it's a empirically useful piece of data. So as a day-to-day clinician, I don't know that explainability is that important. I think trustworthiness mostly is an empirical manifestation that it's working, we can prove it works. But I do think innovation is at risk if we don't understand where the models are coming from, why they're recommending X instead of Y. And I think we have to work on that. The advantage of AI when it comes to innovation is, in many things, the innovation is that something's already happening someplace in the system and nobody knows it. And so its ability to sift through vast amounts of data in ways that no human can and say, it's looking like patients who were treated at UCSF this way, they're doing something different than they're doing it at Kaiser or at UCLA, and it seems like patients are doing better. What might be going on there? So that's a pattern that no human is ever going to pick up. So I think that's the hopeful part of innovation, but I agree with the premise of your question, which is if we're not careful, it can create kind of a calcified system where it bolts in and scales today's practice and doesn't help us get better.
Thank you so much. I appreciate it.
Do you think the journals are going to become more powerful because AI is going to be reading them and using the information?
I don't know that the journals are going to become more powerful because the journals are sort of stressed by a relatively traditional system that's having to speed up, but the speed with which new information is coming, the ability of them to do sort of thoughtful peer review is under a lot of stress and a lot of strain. And there's so many different ways people can get information now. But I do think that part of the reason we need AI is in the old days when I was a medical student, I could keep up with the literature. I didn't read every journal, but I certainly read JAMA and I read the New England Journal, I read the Annals of Internal Medicine, and that was enough. There is no way that any human can possibly keep up with the literature. And there's another piece of this that's going to get even harder. As we get to precision medicine, if I see a patient in clinic who's got high blood pressure, the current guidelines say treat the patient with this drug, and maybe if the patient's over 65, use that drug. The future is if the patient has this gene signature, treat them with this drug, and this other gene signature, that drug, because the first one won't work. There's no way a human can keep up with that. So we are going to need computerized decision support to guide us. And it's going to have to link to what's new in the journals that say that this is the best treatment for this thing, and it's increasingly going to be fueled by genetics. And that just makes the job of a physician trying to remember everything in his or her head absolutely impossible. It's probably impossible already, but we have the illusion that we can kind of muscle our way through.
Jordan?
Hi, my name is Logan Roberts. First of all, that was a fantastic talk. Thank you. I think my question builds off the last one a little bit. You mentioned in your presentation that there are a lot of cases where AI kind of operates in a black box and people don't necessarily understand the math or the full decision-making process behind it. And if the outcome works, then it's sort of okay. I think given that these models are developed by private companies who want to preserve their own image, I'm wondering how you foresee healthcare entities being able to like continuously audit the performance of AI as it's used as maybe not a diagnosing agent, but an assistant.
Yeah, no, I think it's a spectacular question. We're all going to struggle with that. I'm sure we'll be using AI to help us monitor AI, which of course gets to be very circular and somewhat problematic, but that's already happening. So, for example, some of the hallucinations that we saw a year or two ago are now, we're not seeing them in part because some of the companies are building in a second AI to check the work of the first AI, and assuming that they use very different methods, that's a reasonably reliable way of doing it. We are going to be tasked quite appropriately with a new technology to be darn sure that the thing is giving good results. The results can change because of bias. They can change because new literature has come out and says that that thing we thought was right is now wrong. Our patient population may shift. There have been a couple studies that showed that Medicare changed the way they coded a certain diagnosis, and all of a sudden the AI didn't work anymore. And so we're going to have to put in these systems. I got bad news, which is we do a whole lot of change today in the pre-AI day, and we often do it in response to a medical error, let's say, and we're not very good at going back a year later to see whether it stuck and whether it didn't have unanticipated consequences. So I think we're going to be pushed to do this, and I think it's something that we're going to have to figure out, how do you resource? Because if you think about it, we're using 50 different AI tools, and we've got to build in programs that are monitoring their performance in real time and looking for shift and bias. It's a pretty daunting task, and I'll hear people say, oh, you just do it, and it's like, really? How's that going to work? It's a hard one. Yeah. Thank you.
Thank you.
Mark, do we have time for one or two more questions?
We've got time for two more.
Great. Okay.
Fabulous.
Hi, sir. My name is Wang, and my question is a little bit technical, if you don't mind.
There's probably somebody in the audience who can answer it, but it's probably not going to be me. So
Yes.
why don't you give it a shot?
But it's related to AI. You talk about the product paradox and how people did not use computers in recording medical records and things like that. And I don't know if you've noticed, but a few months back, Microsoft actually has a shutdown in their system, an error in the update that causes all of their computers in hospitals, airports to be shut down. And that is my question. If we're using AI, it means we're going to have to use an operating system. Mm-hmm. So have any changes in the medical industry in considering Microsoft, which will be using that AI technology that's going to cause any more further errors in the future?
Thank you. Yeah, it's not that technical. I mean, once we went to computers in general to just store our data, it became mission critical. We needed backup systems and backups of our backup systems. It's not elective that the computers are working, and if we become dependent on AI, then we're going to have to figure out what happens when there's shutdown or we lose electricity or whatever. It's going to be important to have robust security systems, robust backup systems, and it reminds me of the aviation issue where the pilots did not really know how to do their job when the AI failed them. We're going to have to be sure that we're ready for that. In terms of, we're all storing our data now on big clouds, and whether it's Microsoft's or Amazon's or Google's or Oracle's, we're all doing that. which at some level feels a little scary, but I think it was actually scary to have them on paper charts sitting in an open room in the basement of a hospital next to the morgue, which is the way it used to be. There's a big set of battles that are going on in healthcare. This isn't technical, but it's a little inside baseball, so I won't go deeply into it. But most big hospitals in the United States have a single electronic health record system. It's called Epic. They almost have a monopoly. It's not that easy to take a new AI tool and plug it into that. It's not like plug and play. It's technically challenging. And so there is something of a battle going on between Epic, who likes the idea that they basically control your entire workspace, and whether it's Microsoft or Google or 1,000 startups in the Bay Area who are building a tool that is probably better than something Epic is building, because that's what they do for a living. This company is building a tool to be a digital scribe or a chart summarizer. There's a battle over how easy or hard it is, and the federal government is trying to push them to make it as easy as possible to sort of plug and play. And this battle will play itself out in antitrust suits and all the usual stuff as industries vie for primacy. This is a $5 trillion industry. The stakes are very, very large, so you can expect a lot of business battles over the next 5 years. Thank you.
The fear is that if they, how do I say it? The fear is that if someone is using Microsoft in operating someone's body, and then suddenly the same thing happen, if suddenly in a middle operation the computer shut down.
I'm not so worried about the shutdown. I will raise another business concern, and it's essentially an ethics concern, which is to the extent that it's a black box, and to the extent I now begin relying on it to say, oh, this is a patient with high cholesterol, AI recommends this drug. I need to be darn sure that the AI company has not gotten money from a drug company. Or my hospital hasn't gotten money for a drug company. So increasingly, we're going to be relying on the AI for what's called clinical decision support. It's going to help guide us to do the right thing. We have to be really pure in that to be sure. There's sort of the misinformation problem, but this is a different kind of bias where we've got to be 100% sure that there's no business relationship that's coloring the advice that it gives us, because over time, we're going to become quite dependent on that advice.
It's like driverless cars. You still want everyone to be trained to be a driver.
Yeah, I guess.
I mean,
although
it would seem like it could go away, right?
I tell you, George, I was in the back seat of the Waymo coming here, and if the thing decided to make a left turn into traffic, there wouldn't have been a damn thing I could have done. People say, well, you'll never have autonomous stuff in healthcare because it's too important, the stakes are too high. It's like, that's pretty high stakes, and yet the lesson about autonomous cars is also, as you well know, there were 2 autonomous car companies in San Francisco a year and a half ago, and one of them ran over a person, that was Cruise, and they lost their license to operate in San Francisco. So even if the AI is better, it better be a lot better and better not screw up in a visible way, because that, in the history of technology, will set you back very far. There are a lot of people waiting for that visible error to make their case about why it was not ready for prime time.
Ready to pounce, there's no question. Our last question. Thank you very much for bringing it.
Thank you. Oksana here. My question is more about alternative medicine and whether you think it has place in Gen AI and healthcare in the United States, or you think it's going to be completely overseas, kept in there, given that regulations are in place?
Yeah, I think there will continue to be pretty strong regulations. The FDA, I think, we'll see, tomorrow's the election, we'll see what happens, but the FDA, I think, will continue to be a regulatory body that will decide that a medicine is safe and effective, and will look at alternative medicines, and one might argue maybe you don't think it's the right lens, but they will look through a lens. Is there a body of evidence that proves this thing is safe and effective? I do think one of the most interesting things that will happen is that, what I did with that AI was ask a question the same way. I don't know if you're a clinician, but you could have asked the same question and got advice. And yet, if the answer is you need a medicine, right now you need to come see me for a prescription. Or if you need a lab test or X-ray, right now you need to come see me for an order for those things. I think AI will test those premises. As AI gives regular people the ability to have expert level knowledge, those people are very likely to question, like, why can't I now get this antibiotic for my infection when the AI, and it's right often enough, when the AI said this is the right thing to do. And so I think one of the things that digitization always does, and AI in particular will accelerate, is the democratization of care and the democratization of everything. So think about the way you make your travel reservations, or maybe the way you do your taxes. Those were industries where AI or technology came in and basically supplanted the experts. In healthcare, there are lots of mechanisms that defend the experts: licensure, regulations, prescriptions, all of those things. And I think AI will put real pressure on those. And I think we could blow it in both directions. We could blow it by saying, you know, it may be in 5 years a patient can treat their own blood pressure or their own cholesterol. There are plenty of medicines you can get over the counter now that used to be prescription. And yet AI is probably not going to do your heart surgery, and there are certain things where if the AI says you should do it, you probably still should see a doctor. So there's a real tension between democratization and the importance of credentialed experts. But I think that line, which has been drawn pretty clearly for the last 50 years, that's going to become a very fuzzy line over the next several years.
It's interesting that there's already pressure because there's a lot of patients read on the internet that this should be done.
Yes.
And then they try to pressure their doctors into approving something that the doctors don't want to approve because they don't agree. What if the doctors start saying, but AI is on my side, you can't do it?
Well, yeah, that's going to happen.
That's
And
gonna
we're
happen.
beginning to see patients come in the same way they came in 5 years ago or 10 years ago with a printout from Google.
Right.
They are increasingly coming in and saying, you know, the AI says this, or not saying that. And then the doctor says, well, I think we should do, you know, arthroscopic surgery. And the patient's saying, oh, that's good, doctor, because the AI said the same thing.
Yeah. That's a perfect place to end.
Perfect.
So thank you very much for coming. This was the 14th annual Lundberg Institute lecture. Bob Wachter, great lecture. Thank you very much for coming, and thank you to the audience for joining us.
Thank you.
And so ends another event at the Commonwealth Club in its 122nd year of enlightened discussion. Thank you very much. See you again. Absolutely excellent. Absolutely excellent.